we're social creatures. Okay, lead on. And plus, I've kind of developed a little bit of a sore throat today, so I'm gonna try not to speak as much. Anna already noticed my voice petered out in the last meeting.
All right. Let me just make this full screen real quick. All right. So my name is Tomas Tesfasilassie. I'm for those that might not know me, I'm a PGY 4 during doing his research year with the ACS fellowship. I'm from Colombia. This is going to be a works in progress for some of the projects that I'm involved in. I'm kind of giving you an overview of what the project is, what's happening currently, and what the next steps will be. So the first one is our laparoscopic skills training curriculum. In essence, the core of this is to create not just a skills curriculum, but a successful one that can be longitudinal and can be translated to have Hawassa attendings running it and not just have ACS people running it. It's kind of what I'm thinking of when I'm entering into this project. That's kind of like what my goals are and what I want to see out of it at the end of the year. So far, kind of updates from the last time we spoke. I had a meeting with Dr. Belai about the skill session because we had one scheduled for I think 3 weeks ago, and none of the residents showed. And then kind of similar to the issues that I was dealing with at the beginning of my trip in Hawassa, and kind of thinking about the engagement. So we talked to Dr. Belai, and a lot of the residents were saying, they're getting pulled into these different services that might have events or might have something that day that comes up last minute, and they don't have the courage, or they don't have the space to say, hey, I'm supposed to go to a laparoscopic skill session. So me and Belai spoke about that. And what he's trying to do is talk to the other departments, namely ortho and neurosurge, because those are the two ones when R1s are there that they're just so busy that they can't come to any of the after hour stuff. So he said he's gonna try to see if he can get them excused. But for right now, we're gonna try the same system as before, but with more buy-in with Dr. Belai, where I'm having like group chats with him and the people that actually signed up. I'm trying to have some safe faults so that people can not just show up and nobody knows who's supposed to come and stuff. So Dr. Belai will have his next session on 10/10 from 4 to 6. And what we essentially talked about with these sessions going up until February is essentially to have a workforce within the residents that knows how to do laparoscopic skills. And instead of trying to focus on a curriculum right now for the 15 people and saying this is what we're going to do for the next 4 months, it's right now what we're thinking about is mainly getting them comfortable with laparoscopic skills so that when we have the R1 orientation in February and the new year starts, we actually have some people outside of attendings that can be in the skill session and kind of teach the residents. Um, with that said, the other work that I've been doing right now is speaking with Ethicon. I spoke with them 2 weeks ago, trying to get more laparoscopic boxes. I know we spoke about the cardboard boxes that were done in Ethiopia, and I brought that to the attention of Dr. Belai. But the cardboard that is used, asphalt, needs to be specific enough for the box itself. Like it can't just be any normal cardboard that you see. So there's still limitations in that, but we're gonna see what Ethicon can provide for us, and then from that supplement it rather than trying to have a bunch of residents make 15 or 20 boxes. If we can only have to make 4 of those makeshift boxes, then that would be great. So right now, we're just trying to see what we can get from Ethicon, and then from there, kind of work backwards and fill the. Yeah, go ahead.
Are these boxes, are they going to be stored in the hospital, or are they for residents to take home with them?
Yeah.
Or
So right now, all of the computers and the laparoscopic skills boxes that are inside of the training room will just stay there. So there's 3 functioning computers. One computer is not functioning right now. They're getting IT to try to fix that, and then 2 boxes. So essentially 5 laparoscopic skills boxes. Usually we don't have more than 5 people per session, but even if we do, they can just team up. The boxes that I'm trying to get now are very rudimentary, and I think will be very easy for residents to actually take home. Last time when we came, we brought a box and we actually gave it to Dr. Zarasanai, and he took it home with him, and he's been practicing at home. So we're trying to do that, but with the residents, and it can be like we don't have to have 43 boxes, like that's not realistic, but I think we can have like 2 boxes per class that each class can just rent out with each other rather than having all the chiefs like take a box each or something. So that is still within the works. We haven't like figured that part out yet.
Yeah, you might even consider, Tomas, that there is one for every resident for one class, and then they kind of pass it to subsequent years, or something along those lines. So like the second years get, and like make it a production, make it a
Yeah.
production of like having the third years give it to the second years,
Yeah.
and it's an annual ceremony where they get their laparoscopic boxes, and
Yeah.
there's psychology behind that. It creates value, it creates engagement and buy-in, and then but they only have it for a certain amount of time, and then there's also pressure to say, if you don't make use of it, then you've lost the opportunity, and that kind of. So there may be ways to add that kind of psychology into their
Yeah. Yeah, kind of similar
use.
to our loop ceremony, right?
Yeah, exactly. That's exactly what I was thinking
Yeah.
of. Yeah, and because like we're human, right? Because so they're
Yeah.
going to have certain perceptions that you might as well use for advantage, because they're learning these skills. It's not like
Mhm.
it's not like somebody else is learning. They're learning these skills, but make it appealing for them to learn these skills, and also to see. And on a slightly different note, you might want to see if there's ways that once they actually have the boxes and they're trying, see if there are ways to have competitions.
Yeah, yeah. That's kind of the next level of it. I think, what you're saying is very interesting. And the only issue is the fact that we're teaching all of the classes at once. It's not like, in United States where the residents are like threes and above, you're like, okay, you already know because you're doing all complicated stuff. But I think there is a psychological reward to it. And I wonder if we can do that for like the R1s during orientation, or like, the R2s, like, oh, congratulations, you made it through your first year of residency. Like, here's your dedicated lab box, and still have boxes that other classes can still rent out or something.
Yeah, it's just something to brainstorm and to kind of think through,
Yeah.
and consider. So just throwing it out there as an idea.
So Tomas, the boxes are pretty easy to come by. We do that with stages. The big barrier is the instruments that go with it. What's the plan for the instruments?
Yeah, so currently they have enough instruments right now to actually have maybe like 4 more boxes for some of the skills. Some of the, like not pushers, some of the little minute things they might not have, but we definitely have enough tools for 3 to 4 more boxes that people can take home. So we can take advantage of that. And I think we can get more supplies, but I also don't want us to just get supplies and they just stay in that room. So, my goal is when the next time I go to take these boxes and take a few more supplies and see if within the next 2 months, if these residents are actually using them, if it's useful, or if there's another method, or if they're saying, we need more tools, we need more advanced tools. But, for skills 1, 2, and 4 and 5, you only really need 3 tools, so it's kind of like, I think we can make it work. But I agree that's going to be a limiting factor, but I think we can at least for right now, without getting any more supplies, we can make 3 to 4 more boxes just from the inventory that we have at the facility.
The other thing, Thomas, might be to ask the residents what they would like to do, because sometimes getting their input on how they'd like to do it will create more buy-in. Like, ask them, would you like to have a competition? Would you like to have videos? Would you like to have, and so that might also be a way of kind of bringing them into the fold without, explicitly bringing them into the fold.
Yeah, I agree.
And it might also allow you to do an assessment of their needs, and that can, one, be written up, but two, can help you with the sustainability, right? Because they're the boots on the ground. They're the ones who are going to tell you if something is working or not working.
Yeah.
So.
I agree. So the next steps is, it's been very difficult to try to get Dr. Belay and Zarasanai on a meeting. Like I really don't have much direction about the curriculum that they're currently formatting in terms of outside of the draft that they've given us when me and Dr. Price were there. There's kind of two areas that we're working on. One, and I think they're making it into one category, but I think we need to split it up. One is the orientation that we're gonna have, where it's a 2 or 3 day intensive laparoscopic skills like training for the new residents. And there's that part, and then there's a longitudinal aspect. And so right now, from the draft that he gave us, it sounds like it's more of a longitudinal aspect, but a lot of the stuff that he has for the laparoscopic is actually directed to the orientation only. So, I've been looking at some of the resources that you guys have provided me. I just need to like sit down with both of them and see what is feasible. And then also, like you said, get feedback from the residents to see like, okay, where are your guys' mindset on in terms of like learning? Like, did you guys like the skill sessions now? Would you guys like to do like a video and a skill session? So it's kind of like holding up the progress, but this is kind of the next big step, and I'm hoping to meet with him next week to kind of talk about our plans for February, because it's going to be fast approaching, and then I don't want it to be January and we're like scrambling to create a 2-day thing. So, and I also think, if we think about this now, there's a lot of opportunity for us to do meaningful research and get good data about the orientation, but we won't be able to do that if we're not prepared. So, I've been trying to meet with them. Maybe I can not necessarily use Dr. Price, but maybe I can put you in an email also and just say all 4 of us need to meet sooner rather than later, because it's really holding up like what we can do. I can do the skill sessions, but I can't really move on with anything until I meet with them. So that's kind of where we are. If anybody has any.
I think, Tomas, I think that's great too. You can go ahead and include me in an email there, and we'll see if we can find some time. Wednesdays is usually best for me, but we can find some other times when they, when we can meet, and happy to help facilitate some of that as well.
Thank you.
I had Teddy reach out and show me pictures of their lap chole and critical view about a week ago that they're pretty excited doing. So they are still making progress in the OR, but
good.
So
yeah, they presented last Wednesday at the Hawassa Hub ACS Hope Council meeting, and they said they had done 16 lap choles, and they were thrilled with their skills. So Tomas and I attended last Wednesday. So
yeah, I wish I could have been there.
Yeah,
sorry, go ahead.
That's why we were on. That was part of the reason why we were on. Make sure we were involved.
Good.
So I think
there's a lot
Tomas,
of good... you should. Sorry,
yeah.
Go ahead.
No, go ahead.
No, I was also thinking, Tomas, you should make sure you have pre and post test surveys ready for orientation to see if what interest there is or engagement there is, and kind of see if you can get a little bit of assessment before and after from an educational standpoint, and then use that to kind of adapt your curriculum and subsequent plan for the year.
Yeah. Well, and as you do that, that's a topic that we have different things being presented about pre and post tests and laparoscopic skills and things, but this is a little different in that this is the incoming intern year. So you could couch this as the basic skills course, the laparoscopic component of a basic skills course for incoming interns in Hawassa. And if you have some data to be able to show with that, then we could put together a small little article and have that as a presentation as well.
Yeah.
I also want to point out that Saren, one of our medical students, is on and would be delighted to help with this project or anything. And I mentioned that we don't have a student involved in any of these projects. And so Tomas, if you'd like to have a student working with you and kind of helping with some of these things, I think that would be great.
All right. So that's that project. Let's move on. So the next project is a perioperative registry. So this, to me, is to improve the access to clinical data through the establishment of a perioperative registry in order to facilitate research in Hawassa. And this has been a project that's been ongoing for quite a while. And currently we're at the precipice of, trying to get really good data in the data set, and having a lot of buy-in from a lot of stakeholders. So I started from our last meeting, we were thinking about generating these kind of reports. So I generated monthly reports because the way that they actually enter data is not in a frequent time frame. So, doing a 2-week report sometimes might show like 2 patients that were registered during those 2 weeks, but clearly there wasn't 2 surgeries done. And that's just the way that the residents out there have been uploading things. Right now, I haven't been, trying to improve how quickly they upload it. I'm kind of focused on the quality of the uploads that they're doing. So I'm trying to tackle one thing at a time. And the one thing right now is the complication sheets. So we've been notorious about having issues with this for a long time. We implemented some things in July that clearly worked because we got 100% of the complication sheets completed. But when we go into August and September, that has a steep drop off. Now, this can be because, the interns who are the ones that are not surgical residents, but they are general practitioners that do general surgery for, within like a month blocks that come in and out, who they're the ones that are responsible to fill out the complication sheet. Right. So if they're not oriented on how to fill it out, where to find it, and the importance of it, then they won't do it. And there have been interns where I will talk to them when I was there in August, and I would say, "Hey, where's the complication sheet?" And they'll be like, "What is a complication sheet?" So, that's one thing that is currently happening and continuing to happen. But the other good thing that is coming out of this project is we are very, very, very close to having RedCap in Hawassa as a server. So we've already got the web and the database servers set up, and they're working great off of the servers that Hawassa already has. So there was no additional cost for them. Currently, they're having issues generating the emails. So when you fill in somebody's information and the email goes to them and says you can now register to RedCap, they can't do that right now. So they can't have residents like get onto the server that they're using. So Dr. Zuffer is aware of all these things, and we've already been talking about kind of solutions. So he's working on finding a specific RedCap IT person to help with this issue. But for right now, we're kind of at that place where they're ready, everything's going, the infrastructure is already there. It's just this one bug that we're not really too sure why it's causing it. The other things that are coming up is meeting with the residents and Dr. Belai. We'll see if Dr. Belai can join, but the residents for sure. I want to just see where where they are with the research project, where they think issues are. There have been some residents that have reached out to me about improving how we gather data, but the issue is it's basically like what we were doing back in the day, which didn't work because there were so many people in the pot. So, I don't want to just change something to have the same issues come up. So I think this is going to be very critical for me, Dr. Belai, and the research residents and Dr. Zuffer to talk about and kind of get down, because we've been dealing with this for the last 3 months. And, we talked about having the interns and the R1s write daily complications on their progress notes, which we're trying to establish now. We even talked about, similar to what we talked about last time, of having the when a complication happens, like filling it into the complication sheet directly. But again, there's a lot of issues of like who's actually filling this out, like who are these interns that are coming in. So we need like we just need a schedule of like when the interns rotate, like very basic things of like when the interns rotate, when can we get them orientation, like can we have a handoff of like a document where it goes from like one intern group to another intern group, similar to like how we sign off services here, but doing that for these interns so that we're not running into this episode where it's like a month lull of like not having anything. So that's the other thing that me and Dr. Bly need to talk about, and then I already talked about the red cap IT stuff. So that's this one, if anybody has any comments or sorry.
So I have so this is one that interests me a lot because I think it's ever since they started this red cap there in the last couple of years, it's been a real struggle. And the interest and the what interests me is how do we best capture information like this? And not we, how do we set up a system that would allow them to capture information? You think about our own system. How do we capture these kind of things here at your hospital in the US? I know in my hospital at Intermountain, we were never able to capture really good data until we hired somebody to collect the NISQIP stuff. Otherwise, it never happened. As much as you tried, as you have M&Ms, you have people reporting, you've just described a system that you have to month by month get people trained to be able to do it. And in my mind, that's not going to be a functional system. And so the question is to sit back, and we need to talk with Dr. Zafar about this. What within the Hawassa organization would allow something to collect data? First, what is the interest? What is the desire to do it? And then if so, how do we set something up? There needs to be, if you rely on the surgeons to do it, it's not going to happen. If you rely on an intern that's changing every month, it is not going to happen. And we've already documented that. We could write a whole paper using this program over the last 2 years as why it doesn't work. And so I would encourage you and me with Dr. Zafar to back up and think what is the system that we need to design, or the person or the program to make it work. And maybe it's as simple as, okay, we fund, or somebody funds one person to manage that kind of data, because when we did our study in Mongolia years ago, it didn't work until I funded a public health person to go to the hospitals and bang on the door every few days to make sure we're getting all the information. And that's how we got the work done in Ghana for the breast cancer survey. So anyway,
Interesting.
My point is, I think the system that we're working with there is non-functional, and it's going to continue to stay non-functional, and we need to think of a different system. Maybe that's a little harsh, but other thoughts?
That's a great take on it, because I think it kind of feels like I'm saying the same things over and over to the same people, and like I mean I hear you, but I just don't know where they could get resources or where we would find it. But I think that is a discussion. And I know, vaguely from what I remember was Dr. Zafar told me that they might be hiring somebody. And that was like something that was said when I first started. So that's something I need to follow up on.
So one of the things that potentially could do, so what is the benefit to Hawassa to do something like this? And how do we show that? I remember when we had one of our fellows go over and talk about quality assurance, and he was just blasted by the people there because we were looking at being cost effective and say, we're already in a poor environment. How can we be more cost effective? But is it able to show how even in a resource poor environment, you could make progress by getting the right kind of data? Now, we have examples from here at the University of Utah and from Intermountain, maybe you do from other places, What are things that have been implemented based on these data? Not just by getting the complications, but you see the complication and you implement something to make a change, or something within the system, because maybe it's not just complication, maybe it's what you're using, but the amount of resources that it has saved for that institution. You could come up, think of what the benefit is to Hawassa, and then because you have to change mind thinking, what they're thinking. And you've got to be able to do it. And I think that would be probably one of the challenges for this year, is not trying to ram down a program that's not working. Try to figure out how to, if that program's going to work, you're going to have to change mindset and get them interested to see what the benefit is. Right now, I think they just see it as a burden of trying to put something into a data bank, trying to get some data. They aren't so excited about, maybe a little bit, maybe Belay is, but the whole system in general is not.
Yeah. I wonder if we could use the data from our laparoscopic campaigns to prove that, this registry will give us data that can increase surgical capacity building in this hospital. Like, we are resource limited. This data shows us that laparoscopic surgery can decrease the length of stay in this hospital. And we couldn't have had that data if we didn't have the red cap. So or something like that, where we can be like,
Right.
there's a direct, and maybe that's for the administration and the people that are funding the hospitals. But yeah, I think there needs to be somebody that is dedicated to this. And when I was there, we talked about shifting it from the interns who really don't have any buy-in to this to the R1s, because yeah, if you're a surgical resident, you're gonna have more buy-in when you're when your program director or your chair is like, hey, this is important to us. So we talked about that, but they were like, we don't want to put too much work onto the interns and all this other thing, similar stuff that is valid. But I agree. I think there needs to be a different system that we need to think about, because it's not working what we're doing.
I think, Tomas, I wonder if this actually should be brought up at the next Hawassa Council meeting, to say that, there really needs to be a project assistant or somebody in Hawassa who helps with taking the burden of doing the data entry away from the interns and residents, is able to do it consistently. And then what that will do is allow this to be consistent, and then the residents can actually use the data, and it'll automatically be available to the residents. And I think one question along those lines is, how much would it cost to fund somebody like that? And then, whether that's something the ACS Hope would be willing to fund, in part to have, because it's for the hub, right? It's for the 12 different institutions that are involved through ACS. And we could have them work on this as one of the projects, but probably multiple other projects would also need that kind of support. So I think that's where we should kind of push on things. But I think, Ray, if you're on the next council meeting, or I think if you could bring that up, that would be great. And we can certainly push on the other folks, Dodgen and Iverson, and Rodas, to push on this idea of, and Zafara, obviously, to push on this idea of having somebody on the ground. Because I think that's probably the most likely thing. Again, sustainability is an issue, right? Who's going to pay for that person forever? But once that culture is there, then it'll be easier. And I'm sure it's not hard to fund somebody. I can't imagine what the cost would be on an annual basis, but I'm sure it's not substantial to have an admin assistant who can do the data entry. That might be worth finding out, but I think that's
and I think once the residents, right now, I would say maybe 2 or 3 residents are using the red cap data. But I think once they see that it's valuable to their education, and that this is actually something that will make their life easier, because right now the way that they do data is they create a question, then they go to the OR and try to find every single patient that possibly had that surgery, then go find it's you guys don't have to do this. Everything will be there. And I think that is what we need to kind of get across.
And that's very common country by country, by the way. That's the same in Uganda as it is in Rwanda, because all of their degrees require, unlike our residency, all of their degrees require a thesis. And there's no existing data collection system that allows them to do any kind of retrospective study like a lot of our students and residents would do. So then they have to prospectively collect that information or try to, and because there's no way to look for charts. I mean, most places, like you write something in a chart and you give it to archive, you'll never find it again. So, you know, I've yet to see one place that has made that work. So there's no sort of continuity in data at all. So that's a huge thing. And that's the benefit we have to sell to the residents to say, make it easier for you to collect and use this information. But we have to take the workload off of them.
Yeah. I wonder if we can also see if we can incorporate this into the new EMR system that they're trying to create.
Yeah, absolutely.
Because
Absolutely.
it sounds like that, like they essentially stopped everything and they were like, we're going to get this done by September 30th. And I wonder if we can kind of parry these together, because you know, all these projects are like very similar in terms of like, you know, overlap. So I think those are two things: the coordinator, and then seeing if there's a way for us to get buy-in from the institution to get this a part of the EMR system early on, so that, you know, maybe we can save us issues in 10 years or whatever.
Okay, sounds good. To Dr. Price's point in the chat about getting instruments. So Dr. Rockwell just mentioned that he gets instruments from our outpatient surgery center to take to Ghana, and he's going to put in a word there later today. I'll send an email, and this could be another way that Saren could get involved, you know, to kind of go and, you know, grab that and that equipment. And Saren can also help with actually going to Ethiopia at some point in the next year. And so you know, could be a good person to kind of take some of that equipment and kind of help the trainees set up their boxes, et cetera.
Yeah, and there's, like I say in my thing, I've got a call into Globus before when I was medical director at Swanson Family Foundation, we really get some instruments from them for our laparoscopic work in Mongolia. So I was going to reach out and see if they currently have some laparoscopic stuff down there. There's usually a little bit of a charge because of stocking fees and things, but it's very inexpensive. That's specifically a group that works to support medical missions, so they may have something. But there's some groups like that around the country. And there's some back east as well. I think there's a guy out of Buffalo that runs, I'm trying to remember, trying to find his name and things, but and even Mustafa, I think he may have some, who was one of our fellows, may have some contacts with groups like that we, you know, may be able to find if there's some.
But I don't
donate an instrument. So,
but Ray, yeah, do we need a handful for them to train with, or do we need more for them to use in the OR? Because if we need a handful for them to train with, maybe we don't need to do more than just get some from our institution, from, you know, either
it depends on how many need. Like in Cape Coast, we've committed to set up 6 training boxes for a training center. And that's the most expensive part, as we've looked at. The FLS boxes, along with the instruments, cost $6,800 per box. That's crazy. And screen and instruments and everything. You can get the box without the instruments, without the screen. It comes with the box and the little skills for about $1,200. I was just with our Center for Medical Innovation director in Mongolia. He's offered to look at it and see if he can 3D print them. So I think there's some options to look at with the training boxes. So we've got Ethiopia, we've got Cape Coast, potentially even further things within Cambodia. So the Navy needs to have not just, you know, if we have lots of instruments here, I don't know what we're going to come up with Intermountain and the U. But you were talking about 3 or 4 boxes and 6 at Cape Coast. That's 10 times all those instruments. That's ends up being quite a few instruments. And then if you start talking about more boxes in Ethiopia, you know, it could be 20, could be 25. So anyway, that was just my thought, is that if we need more, there are other options that we can begin to look at.
Yeah, that's a great point. Brad?
Yeah, I think that the instruments that I've gotten, they don't come on any regular schedule, or there's not a month during the year where they discard them. So that the 2 options, either some instruments become sort of obsolete. Basically, they're still good, but none of the surgeons, maybe the OR gets some new instrument set, and so the old one becomes obsolete, but it's still good. Or an instrument breaks, they send it for repair. If it's repaired, it goes back into the system. If they cannot repair it, then it gets thrown out. Those are the ones that I've got. And I mean, they're not perfect, but they're still pretty good. So it might be, Ray, I'm thinking if there's someone there's probably an IMC OR instrument repair person.
Yeah,
And if they had a message, instead of throwing something out, will you just put it in a box with my name on it, and I'll stop by every 2 months to see if there's anything in the box.
yeah. Phil, our biotech that goes with us to a lot of these places, is the one who does that, and so he's working on that right now at Intermountain
Yeah.
fluoroscopic stuff.
And even in Ghana, they've had stuff that, like some neurosurgery instrument that's going to get thrown out. And I say, do you want it? And they say, yes, we'll trade, give it to me, the plastic surgeon. I'll go to neurosurgery and give it to them, but I can then ask neurosurgery for a favor for something else, or they'll barter with stuff.
You would have been good in MASH.
That's some good scheming on the part of the Ghanaian surgeons. But yeah, I think maybe Tomas, one thing would be to make a list of the equipment that we need. And then Dr. Rockwell, if you can connect us to the person, and I'll see if maybe Saren can be our person who kind of stops in and checks in periodically to see if those instruments are available and kind of grabs them and just keeps Saren, you can just keep it in our CGS offices, but we can kind of start stockpiling, and then we can kind of vet and see, do we need to take these to Ghana or Ethiopia or Cambodia, or what makes sense, and as they're available.
There are quite a lot of these warehouses that they support mission groups and other things, and they're all over the country, and they come and go. But for urology, which is very equipment intensive field, cystoscopes and also laparoscopes and all, we've acquired a lot of that stuff through these different groups. And as Brad said, there is not like a consistent stocking. It all sort of depends on which hospitals are upgrading from whatever they had before, and they donate it, as perfectly functional thing, but it's not the newest and greatest thing. And so we haven't really availed ourselves too much of that, but we recently had, I think you met Mawenyo, who was here from Ghana, and she developed a shopping list of all the things she wanted to take back to Ghana, having seen what they were using here. And she was able to get pretty much all that stuff, either while she was here or shipped to Ghana directly, once she knew what she wanted. So there are ways to get all of this stuff. But that doesn't mean it's going to be repairable on site, which is a different kind of a question in terms of biomedical engineering, if it's being used in the OR as opposed to for training purposes, like in boxes.
All right, let me move on to the last one, which is the
sorry. That great point, Dr. Dries. I think that's what Dr. Price was mentioning earlier as well. So thank you. I think we'll come up with a plan, Tomas, of how to.
Before I left, I created an inventory list of everything we had there anyways.
Cool.
So it'll be very easy for me to go through there and see like how many boxes we actually can have and everything.
Okay, cool.
So this is an optimized study. This is optimizing pre-hospital trauma interventions and medical emergency systems in Ethiopia. This is a comprehensive evaluation of the pre-hospital system in Hawassa. with a potential scale up to Addis Ababa using a mixed method approach. So currently, both Hawassa and MCW IRBs have been submitted. We're just waiting approval at this time. You know, we actually talked to the emergency room director, and he was concerned about buy-in still, because it's been a while. Like the way that it worked out was like we were interviewing them as if like we were cranking up to like start the project right then and there. And so I don't think I or Faye did a good job of setting expectations of time frame, which is our fault. So now we've been thinking about ways to kind of keep people engaged. And one of the things that kept coming up over and over, and even in the readings that you've sent me, Dr. Jaraman, is this about education and training and what that should look like, how often it should be. So all of the paramedics, quote unquote paramedics, are BLS-ish trained. That was 3 years ago. So now what we're trying to do is plan an interview, a Teams training course for them to still be engaged in this process, because they're actually not getting paid that much money from what we are seeing. And a lot of them just want to help their own city out. And so I think this is one way that we think we can get them involved. And then the other is setting up a meeting with the Quality Survey Corps at MCW, which Faye is working on. So not that many movements currently, but I think this training is going to be a big step for the people.
And I thought that there was some discussion about writing up this initial assessment as well. Is that something that?
Yeah, me and Faye haven't like talked about that any further, but Dr. Iverson reached out to me because she wasn't going to be able to make this meeting, and we'll meet with each other and see what we can do, since we have that data anyways.
Yeah, I think that would be good to write up and sort of as a, you know, here's the situation now and here's the potential roadmap. I think that can be useful to put together.
Mm-hmm.
Yeah, great.
So those are all the projects.
I think WHO has a EMS training course that I newly heard about just in the last few weeks, that my UK partner, who's collaborating with me in Rwanda, mentioned like in passing. So I'll see if I can find some more information about that, to see if there's a way that can be done in Ethiopia or not. Like if it can be done, if I don't know to what degree it's finalized. So we'll see if I can investigate a little bit more. Okay, all right. Well, great presentation, Tomas. I think that was really helpful to kind of walk through all those different projects and have some clear plans. It seems like for the equipment stuff, you know, I've been texting with Sarah to see if we can kind of have her take care of that. I think that would be great.
Okay.
Yeah. Yeah. Any other?
Oh, the other thing I wanted to bring up, these Faye really wants to make these meetings, but her schedule, like Wednesdays are like the worst times. These meetings are always on Wednesday, right? I just wanted to.
Yeah, and I mean we can move them. We just made it part of our routine, because that's when most of us are available. So, but if we can potentially push it one way or the other on Wednesdays.
I'll email you and see what we can do, because she definitely wants to make them.
Yeah, it would be great if we can move up or down an hour, you know, on Wednesdays for just the Ethiopia meetings. We can potentially do that. So thoughts from anybody else?
Sorry, I missed the call. I just joined like 10-15 minutes ago, and
no problem.
I caught up with the discussion about the equipment. I think I mentioned this to you, Sudha, just to follow on the remark that was made by Catherine. We have a very large warehouse here in Salt Lake City. It's called Globus Relief. You probably know about it. And surgical equipment is one of their forte. So
Yeah, that was when I mentioned that I put
Yes.
a call into them to see what they have for laparoscopic equipment. And I used to have contacts down there. Who's there? I know actually Mitt Romney is one of his kids is on the foundation board there. Do you have any direct contacts with anybody down at Globus?
yes, I know the general manager. She's a lady from Iraq. Her name is Shaima. I'll send you her. I'll send you her contact information, her phone number, and email.
That'd be great if you could do that. Yeah, I was gonna see if I can even go drop by there this afternoon, but if I got that contact, that'd be great.
Yeah, absolutely.
Look at that. That's just amazing, right? I mean, this is the beauty of having a regular meeting. Like, it's like we just can solve problems and like figure out how we're going to move this forward. You know, just it's fantastic. That's really great. Okay, well, it looks like there's movement there. All right. Any other thoughts or comments from anybody else? Dr. Rockwell, do you have any comments? I see that you're unmuted.
Oh, no, nothing to add.
And Dr. DeVries, do you have any comments? I see you're unmuted.
No, I think the points earlier about having surgeons do the complication sheets are totally apt. I've never gotten them to do them anywhere on the planet. You know, they're just, it's hard enough to get them to do op reports. You know, it's just plain hard. And so finding public health people, if they will engage. I mean, that doesn't happen in the States. You can't get a public health person in an OR or anywhere near surgery. You know, I mean, it's like a whole other planet. But if you can do that in Ethiopia, that would be brilliant. And in other places where there isn't such a wide gulf between the cultures of public health and surgery, which we've been trying to bridge for a long time and so far not successful.
It's a great point, Dr. DeVries. I so appreciate that. Even though many of us in surgery now have slowly gotten public health degrees, it's that way, not the other way around, right? The public health folks are still like not quite interested in surgery.
We tried for years to get something surgical onto the public health conferences, and we would go to the public health conferences and we would get absolutely nowhere with it. You know, I mean, it just was not successful. And after a while, you just get tired of beating your head against a wall.
Yeah, absolutely. I've presented at APHA and ASHDM, which are some of the main public health bodies here. But you know, it's like I'm the lone surgery representative for like the entire meeting.
Yeah, we used to go to APHA, and after Ray and I wrote the book on global surgery and public health, we really did make a hard push to get these communities to talk to each other, and it was kind of a one-way conversation, I think.
Yeah. Ray is smiling in agreement. I feel like it's a very deep, it's a deep comment, Ray.
It's just, we even at APHA, we had meetings and trying to set up a committee to specifically for global surgery within the APHA, and we're making a little progress, but it was really pushing from the outside in. And
yeah, I mean, it's a little bit like trying to get CUGH, which is also pretty much a public health sphere. You know, I mean, how many years will you bang your head against a particular wall?
Yeah, fair. But to go back to Ethiopia, Tomas, one thing you might want to consider, and I don't know if there's a public health school or not at Hawassa, but it might be a good idea to see if there's a coordinator who can help with data entry, but then the public health students can work with the residents on their thesis projects, see if there's a way, and that way there's some more buy-in to have a coordinator or have the data or have the public health person engaged in the data quality management or something along those lines. Again, just things to explore. You know, who knows if any of these things will work.
Yeah, good idea.
Yeah. Okay, I think if that's it, I think this has been a very successful meeting. I really appreciate everybody's thoughts and ideas. I think Mo, you need Ray's email, which I'm going to put in the chat. But I think we have some plans, and I'll connect with various of you by email to kind of get other things organized, and go from there. Great, strong work, Tomas. And then, oh wait, when is your next trip going to be? When should it be? At least seems like at least January.
That's what I was thinking.
Yeah.
I was trying to split all my trips up by like 3 to 4 months, just so we can like do things in the middle, and then
Yeah, exactly.
I can do things. And my next trip, I'm gonna try to have it closer to like the end of the fellowship, so that we can do stuff. And
Yeah.
so I think my
Yeah.
last trip will probably be
Fantastic.
in May or something. I don't know. I haven't decided, but
Yeah, that sounds fantastic. And we can talk more about that. But okay, January seems like a good plan. And I think Ray, you're thinking about going to Cambodia then, so you wouldn't be going to Ethiopia, but
That's
all right.
When did you say you're going when?
I was thinking January 6th is the first Monday of
That's
January.
what I thought we talked about. Yeah.
Yeah.
Yeah, we'll be in Cambodia like the 11th or the 25th or so.
Yeah. Well, we'll see if we'll see if
I'm
any of
gonna
the
see
other
if
folks.
Faye can also come around that time, because she said she might have like winter break stuff going on then, just so we can work hopefully by then the IRBs will be completed, and we can actually get some headway on the pre-hospital stuff.
Yeah, fantastic. Okay. All right, great. Okay, well, keep us posted. We'll see you next month. And thanks, everybody.
Thank you, everybody. Have a good day.
You too.